We're signing on in Zoom so you can get your CMEs. We see you and good morning, everyone.
Right, and so the session is now being recorded, and please do not include any confidential patient health information. Roll call is required for CME and CAU certificates. So I noticed that people are chatting in, so we know that people are in, and or you can call if you're on the phone or on audio too. You can announce yourself. Looks like everybody knows how to join in on the conversation, and so I don't have the disclosure and the accreditation statement on the online, so there's
nothing to
disclose. And then we don't have case consultation today, right? So
correct.
Otherwise, there'll be a reimbursement, and you can contact Kevin for that. So now we can begin roll call, and I'm seeing that everybody's chatting in.
Okay, and around the table we have...
Hi, I'm Jane Beckley. I'm a nurse practitioner with Envision New Mexico, working with our Fronteras teleclinics.
My name is Maya Trujillo. I'm a quality improvement specialist with Envision New Mexico.
And I am Carol Conley, your facilitator for Adolescent Health Initiative. Welcome, everyone, to Studio Envision. We are so happy to have our presenter today, Janice Whitlock. PhD is a research scientist in the Bronfenbrenner Center for Translational Research. She is the founder and director of the Cornell Research Program on Self-Injury and Recovery. Dr. Whitlock received her doctorate from the Department of Human Development at Cornell University in 2003. She has a master's in public health from UNC Chapel Hill and her BA from Berkeley. She has been dedicated to linking cutting-edge science with on-the-ground efforts to support and enhance the lives of youth and their families. Her research focuses on developmental and contextual contributors to adolescent and young adult social and emotional health and well-being. She is the author of multiple papers and projects in these areas. In addition to her work in non-suicidal self-injury and suicide, Dr. Whitlock writes and speaks on the role connectedness and resilience plays in the early detection and prevention of mental health challenges. Dr. Whitlock, thank you so much for joining us today, and I'll turn it over to you.
You're so welcome. First, let me make sure you can all hear me all right. Is this okay?
We can hear you.
Okay, fabulous. All right, so I'm really glad to be here with you. I just need to let you know it's always a little strange to do a webinar because I can't really see anybody, and I find it very odd to be talking to a screen. So if I've gotten a little better at being able to pace myself, but if I get going too quickly, because I'm not getting a lot of feedback, please feel free to let me know to slow down.
Yes, thank you.
Okay, so I'm really glad to be here. This is the third time doing this, and I have a lot of the same kinds of material to cover, but I wanted to also throw in a little bit of additional resources that we have available to you. Oops, I just realized learning objectives is lean ring objectives. It's so funny the things you notice as you're starting out. I wanted to just put in a slide here about what I'll cover. I mean, in general, I'm going to be doing some background. I'll be doing some of some nuts and bolts of the common presentations of self-injury in adolescence, comorbidities, or what goes along with self-injury and the relationship to suicide in particular. We'll have a little bit of time to cover detection, intervention, and resources. And before I forget, I wanted to let you know, if you Google Cornell and self-injury, you will come up with our website, and there's a whole bunch of downloadable free resources there on the resources tab, as well as some training information. So before we get started, I want to identify the definition of non-suicidal self-injury. We define it in the States as the deliberate, direct, and self-inflicted destruction of body tissue resulting in immediate tissue damage, purposes that are not socially sanctioned and without suicidal intent. It actually took us as a group of scholars some years ago, about 6 or 7 months, to come up with this. For a whole bunch of reasons. The two pieces I want to make sure that are very clear here is the for purposes not socially sanctioned. We exclude tattooing and piercing, even if excessive, because for some subgroups it's undertaken for aesthetic purposes and is socially sanctioned. It is pretty clear from some of the research that looks at the overlap with tattooing and piercing that there is probably some similar shared function for some people, but in general it is not considered part of the definition. And then by definition, non-suicidal self-injury is without suicidal intent. But as we're going to talk about later, there is an important relationship between non-suicidal self-injury and suicidality. And it's really good to be able to keep that in mind, especially when you have a young person or an adult who's injuring, because it does and should trigger assessment of suicide, not just at the time that it's detected, the non-suicidal self-injury that is, but subsequently as well. So why worry about it? I mean, there's a variety of good questions out there about if it's something that tends to pass, if it's something that tends to be associated with adolescence, if it's something that isn't necessarily going to be lethal, then why worry about it? And there's a few things to think about. One is that it usually is a harbinger of other more lethal conditions, largely because I think of it as sort of the canary in the coal mine in a way. We get a red flag that something's going on. It indicates underlying distress that does increase risk for suicide thoughts and behaviors in a lot of cases, and or other chronic conditions like pretty severe depression or anxiety. It can cause unintended severe injury. I think, I can't remember the stats in our studies, but like 25 to 30% of people who said that they chronically self-injured in some of our earlier studies said that they had unintentionally cut themselves deeper than they intended. And in almost all cases, all but about 6% of those cases, they did not seek medical attention. And in fact, they were even more likely to go into sort of a shame cycle and not tell anybody, even though they really, really needed to be seen by a medical professional because they often needed stitches. And I've just heard some amazing stories about people going to the internet to find out how they can treat a really deep wound, or actually stitching themselves up by themselves with no anesthesia and no medical professional nearby. It can lead to lasting disfiguration. This is the thing that I've heard the most that I never really thought about during the early days of this research, is it really does leave scars, physical, visual scars, that is the one part of somebody's history that they often can't hide. So I was talking to a young friend who injured when she was 15, and I talked to her, 10 years later, and she said, of all the things that happened when she was a young person, and including self-injury, but also including a variety of other things, the self-injury was the one thing that she couldn't sort of escape. And she worked in a home with older people, and she really loved doing work with older people, but she always wore long sleeves, even in the summer when it was hot, because of her concern that they would ask questions and that she wouldn't know how to answer them, and that her boss, most importantly for her in a lot of ways, would ask questions and would consider her potentially a risk because of her history. So that's something that people often don't think about, but that is just one of the side effects of self-injury. It can be contagious institutionally. So anybody, any of you out there who's worked in schools or in inpatient treatment centers, it can definitely spread. It tends to, be kind of sexy for some, in some instances, for some people, and it's not ridiculously difficult to stop when it starts to spread in people for whom it's really not their sort of drug of choice. But the deeper into the behavior people get, the harder it is for them to stop it, and it can be very disconcerting for everybody that needs to treat it or live around it. And then lastly, it's really stressful for people who love and or live with someone who uses it. I can't tell you how many parents I've talked to who really have ended up living lives of having conversations that they could never fathom because they walk into a bathroom. They have to talk to their child about, making sure that they don't leave blood in the bathroom for their siblings to see, et cetera. And it just can create a very altered reality for people. So I wanted to throw this in here, this idea that self-injury occurs in a larger context. And there's two pieces to talk about, although one I'm not going to go in depth, but I'll mention, which is that I see self-injury as as begging a larger question of why this, why now. When I started to study this early in the 2000s, I was fixated on this question of what makes this behavior so appealing? How does it have so much traction in sort of community populations of young people? What is it about our society? What is it about our relationship to violence that makes this have traction? So there, it occurs in a much larger context within society that I think just is helpful for us to scope out and say, how are we creating conditions in which young people feel like this is a way to cope? And what kind of conversations do adults need to be having about this world that we're creating? So that's one larger piece. The smaller piece, and the one more direct here, is that it usually doesn't occur in isolation. So there's often a variety of other things going on for someone who self-injures. So on the left side of your screen, you see sort of what we would consider direct self-harm behaviors, and that includes both major and atypical self-injury, which, major would be like things like inoculation or autocastration, whereas atypical is things you don't see very often but do come up, like mutilation of the face, eyes, breast, genitals, or multiple sutures. And then what we consider common self-injury, which is the types that probably most of us see most often: cutting or burning, doing things basically to the surface of the skin. And this also includes suicide attempts in terms of direct self-harm. But there's also, as you see on the right-hand side of your screen, it's what we consider indirect self-harm. This is that big category of things people do that really hurt their bodies and or themselves in larger ways. That includes things like substance abuse, eating disorders, unhealthy risk-taking, use or misuse of prescription drugs, one's own prescription drugs or others, and then other kinds of risk-taking behaviors that can damage the body. So the treatment specialists I know are always careful to let people know that it's really important to figure out what else is going on, because in some cases, the self-injury, especially if it's the more common forms of self-injury, are not the most critical thing happening. They might be part of a constellation of things, and it may be that treatment goals would have self-injury a little further down on the list. So, for example, a really bad eating disorder can be much more lethal than non-suicidal self-injury in its more common forms. So this idea of figuring out what the big picture is for somebody and looking at the common denominators and trying to treat those, and then also understanding that self-injury may not be the biggest and most critical thing going on, is pretty important and helpful. And in general, the more complicated the cases, as you all know, the more time it's going to take, and the more modalities are often needed in order to deal with the underlying issues. So these three on the left-hand side, the major self-injury, atypical self-injury, and common forms of self-injury, are the things that we're going to talk about. Well, that are all categorized as non-suicidal self-injury, and I am in particular going to spend most of my time today talking about the common forms of self-injury. The major self-injury and the atypical self-injury are both. If you ever see any of those, you would want to get someone in treatment, or definitely assessment right away. The common forms of self-injury are a little different, and the protocols for dealing with that, depending on where the young person is, are going to vary somewhat, and not going to usually include, like, get somebody to be assessed as a potential inpatient. All right, so within the common forms of self-injury, there's a lot of different forms, and I'm only going to put the things that we see sort of the most regular. Oh, sorry about that. That isn't what I was going to say. I'll do that in a minute. I'm going to tell you that there are three different categories or buckets of within common self-injury. So there's superficial injury, which would be people who have relatively low lifetime frequency of self-injury, and they tend to use, and here's the critical part, very few forms of self-injury, and those typically result in mostly superficial damage. So wound interference or scratching, for example, can look and be disturbing, but rarely will they lead to death. And we find that, so there's been lots of studies that look at whether you can group kinds of self-injury, and if, which ones do you worry about the most, basically. And we all tend to find these three basic buckets that I'm going to tell you about. Superficial is the least worrisome, although in comparison to people who don't have any self-injury, this group of people tend to have elevated anxiety, depression, and or suicidal thoughts and behaviors. But of all the people you're going to worry about on the self-injury spectrum, these are going to be the people to worry with the least about. The next category we find is what we call the battery or light tissue damage category, and they also tend to have fairly low lifetime frequency, so they're not doing it all the time. If you ask them how many times in their life they've done it, they may say, less than 10 or 15 times. They tend to use several forms of self-injury, and the worst form they would ever use would result in moderate tissue damage, like bruising and small punctures. Interestingly, in our latent class analysis study, 64% of all self-injurious guys were in this group, because males are more likely than females to punch or hit themselves or objects with the intention of hurting themselves. So it looks like external focused aggression for guys, but they know that there's an internal component, and they're seeking pain. This is generally of shorter duration than other classes, and in comparison with a superficial injury, they're a little more likely to have some of the negative outcomes I just mentioned. And then the highest severity group is this, what we call the chronic high severity injury. They tend to have high lifetime frequency. They tend to use multiple forms, and the worst of the forms they would use could result in severe tissue damage. They're more likely, the most likely of all the groups to conform to the classic cutter stereotype. They report having routines. They usually have paraphernalia they use. Habituation is my way of avoiding the word addiction, but they often show addictive kinds of attributes with self-injury. So the desire to injure comes up even when there's no trigger. They need to do more over time for the same effect, and so forth. They tend to report hurting themselves more than they intended, and they tend to perceive that it is actually having an effect on their lives. And this is the group that is the most concerning in terms of their risk for suicidality and severe depression and anxiety. In general, when we look at how common this is, we're all finding more or less the same things. And interestingly, it's not just in the US. There's the studies that have happened around the globe are converging on some pretty standard numbers. In general, lifetime estimates range from, say, 7% up to 25 or so percent in adolescent populations, and higher, of course, in clinical populations. A real recent meta-analysis that took all of the studies that have been done to date on prevalence and looked at whether it could converge on a number, estimated that about 17% of adolescents have ever self-injured, 13% of young adults, and 5.5% of adults. What's interesting is the majority of those people, 75 to 80%, report repeated self-injury. So it's not just a one-time thing, it tends to go on. And if the question is how many people are walking, or how many young people on like a secondary school campus are walking around actively injuring now, I would guess for a secondary school campus, probably 10%. On a college campus, maybe a tiny bit less, but not a lot less.
Wow.
Yeah, it's pretty high.
Yes.
In terms of demographics, what's interesting is we see very, very few predictors of self-injury. I mean, early on, everybody thought this was going to be sort of a middle to upper class white girl thing. That has not been borne out at all by the research. It's slightly more likely to be female than male in the studies where there's a difference, but there's a lot of studies that show no difference in gender. There's no SES connection, socioeconomic status connection. There is a trauma history connection, but not an SES connection. Very little race connection, so pretty much, regardless of race or ethnicity, it seems to be fairly evenly distributed. There's a few caveats there, but in general, the differences are very minimal. The place where we see the most difference is sexual orientation, and it's, no matter how the question is assessed related to sexual orientation, it always turns out that the people in the middle of the spectrum, so people who identify as bisexual or questioning, or who are categorized based on their, the way they respond to a different set of questions, they're not asked to self-identify, that they are much, much higher risk than people who identify as straight or people who identify as fully gay or lesbian. and it tends to be driven very much by females. So it's females who are in the middle of the sexual orientation spectrum. Like in multiple studies, about 50% of people, of women in that category have self-injured. So there's a number of enterprising young scholars now that are trying to figure out why that is. If it was, I mean, there's definitely the bias factor, but it's the fact that it's solely, or not solely, but so much more likely to be females than males suggests there's another dynamic going on. So I hope maybe by next year we'll have some additional information about that.
Yes.
The most common behaviors tend to group in these two. I'm going to show you two slides. There's actually many more than these, but these are the things that are the most common. So in terms of common, and these are in order of that we have found in our studies, which are very similar to other studies, what you're likely to see. So severely scratching or pinching skin or fingernails or other objects, but to the point that like blood remains or really deep marks on the skin happen. Cutting is what we all hear about. Banging or punching objects to the point of bruising or bleeding, but with the overt intention of hurting the self. As I said, it may not look that way to the outside, but they know that it is. Same thing, punching or banging oneself. Biting to the point of bleeding occurs or deep marks remain on the skin. Ripping or tearing skin. This can be things like taking cuticles and ripping them all the way up to this finger and so forth. Chewing up your lips and things like that. Pulling out hair, eyelashes, or eyebrows, but with the overt intention of hurting oneself. Wound interference, burning, and in what's called embedding, rubbing glass or other sharp objects into the skin. Those are the sort of the dominant categories. There is more, as I said. In terms of assessment, if there's three pieces of information that if you really don't have much time with a young person and you really want to assess risk quickly, here's what I would suggest. Assess lifetime frequency of NSSI. So how often have you ever done this? And you can have a marker of like, that's not very much. Say it's less than, say, 10 or 15 times over the course of 10 years or 5 years. Or a little bit more, and it's like the moderate, and then high would be like over 50 times in a lifetime. Assess the number of forms. I'd say the thing that most parents and most adults are most unaware of is that if somebody is injuring, 70% of the time they're using more than one form. We may see only one form, we may think of it only as one form, like they cut, and in our mind that's what they do, but the reality is they're probably using multiple forms. So the more forms they're using, the higher their risk is. And then the last question is, what's the worst of the form they're using in terms of its ability to do lasting damage? So once you have those three things, you can group them, you can categorize them according to those three categories that I talked about earlier, and that will give you a quick and easy assessment of how much interference, or not interference, but how much intervention should you be doing right away. Most common locations is like everywhere on the body. There's really no place that people don't report, but these are the places in order of from left to right that you see. I'd say there's a little bit of difference with females and males. Guys are a little more likely to have injuries on the hands, and because they are more likely to punch things. Girls are a little more likely to have it on the wrist, stomach, and thighs. But other than that, there's not a lot of gender differences in the way that it appears or where it appears. I think we talked a little bit about this. Females are a little more likely to scratch. Now, I say a little because we did a whole analysis of gender. We didn't have, we only had enough power to look at males and females, because at that point, so this was like 6 years ago, there was far less other identification in the studies. Now there would be more. So I can't say a lot about that. We just didn't have enough numbers to actually be able to say much of value. But if we looked at males and females, there were far fewer differences by gender than I expected to find. And we looked at all sorts of elements of self-injury. Here, these are the things that I found that were probably the most meaningful, and none of the differences were that big. Females were a little more likely than males to cut and scratch, although there's plenty of men who do that. Males were a little more likely to punch themselves or objects, but with conscious intent. Females were more likely to injure alone and to have a ritual than guys. What was interesting about the guys, and again, this is not a huge difference, but notable is that they were more likely to injure in groups or to let others injure them as part of a ritual. So they might start in a group with a dare of some sort, like, who can hold the lighter underneath the arm the longest and that kind of thing. But then there was a subset of young men who said they noticed that there was a physiological effect and they pursued that again later on their own. But they might go back into a group circumstance and do it again. And then females were much, much more likely, it's the one place where there was difference, to seek and receive mental health treatment. So that's one of the reasons why so many mental health providers, at least historically, have seen this as a female phenomenon, because men are just much less likely to show up in the system. A few other things to note, about 20% of individuals who self-injure report doing it more severely than intended. I talked about this a little earlier. So it's really important to assess experience with this, if this has ever happened, and if it has, to discuss safety measures, because a lot of them don't know how to physically take care of themselves, and they're very reluctant to go get treatment. And treatment, I mean like get stitched up, which is typically what they need. Most report injuring in private, but some do injure as part of a group membership or ritual, and we talked a little bit about this just a second ago. I should just say the one just above there, assess the extent of group engagement. There are definitely a number of schools or school professionals I've talked to who said that they're aware, say like in New York State a few years ago, 18% of respondents in schools said that they were aware that there were kids who were injuring as part of group membership, sometimes on campus and sometimes sharing implements, which is a whole nother ball of wax if you've got people sharing a blade, for example. So that's just something to keep in mind. It's often episodic, and this is really true for almost everybody. Usually there are periods of high and low activity, and somebody will say, I haven't injured in a long time. It does not mean that they will not injure. Often what happens is days, months, weeks, even years can go by before another sort of episode happens. So it's really good to check in periodically. And we find that the risk of suicidal thoughts and behaviors it gets lower as the history of self-injury recedes into the background, but there can be even a couple of years in between the last NSSI episode and a suicidal behavior. So there is something, it's just something to kind of keep an eye on. It tends to feel like it's over, and it really isn't over, and that's really tough for parents in particular. And it definitely can become habitual for people. So about 1/3 of people in our studies, almost all the ones in that higher classification, the more worrisome group we talked about, said that it became sort of an addiction for them. They just needed to do it. They needed to do more of it. They didn't always have to have a trigger, and the urge would come on. So it is definitely useful to assess the degree of entrenchment and to use harm reduction models as needed. A lot of times, basically, people can't just stop. So any system that says you have to stop without a lot of supports in place for that are probably going to be running into power struggles with young people around this, because it's tough to just walk away from. The primary risk factors are all of these things. I'm not going to go through all of them with the exception of a couple, because these are the things that we tend to see for everything. I mean, this question of like, what is the specific trajectory that leads to self-injury is one that's really tough still for us to answer, because so many of the things that put young people and adults at risk for, negative life events are common, and self-injury is no different than that. The two pieces that I think that are kind of interesting, or that I always try to call out, especially with parents, are individuals with a history of emotion dysregulation or sensitivity tend to have higher self-injury likelihood. So for me, this is important, because basically the way it's useful to frame it, especially for parents, is you probably have a young person who's very perceptive emotionally. They perceive it in other people, emotions that is. They perceive it in themselves. They're sort of more acute to antenna for emotion than your average person, but they have no idea what to do with it. It feels overwhelming, and they just don't want it. And so either they dissociate and shut down, especially if they have a history of trauma, or they feel subjectively in their body so much more emotion then they know what to deal with and they need to discharge it. And self-injury becomes a way to do that. So it's a gift that needs some cultivation and some training around. And they also tend to have a tendency toward negative cognitive styles. So they also adolescents in general tend to be a little more negative. All of us, when we're adolescents, it's just developmentally part of what happens. Our filters are a little more negative than they're going to be other parts of our life, thankfully. But people who injure tend to have more gray filters in place inside for a whole bunch of different reasons, some of which can be traced to events and some they just kind of came in with. So this tendency to be really perceptive, but to run the perceptions through a negative filter can really, like a negative cognitive explanatory style, that can really be problematic. So it can really create a lot of agitation that they want to discharge, and self-injury has that. One of the interesting pieces here, because I don't know if I'm going to talk about it later, is it's turning out that people with self-injury history don't seem to have a hard time. So in terms of treatment and intervention, it's not so much that they need to understand negative emotion. They get negative emotion. Like, they're really comfortable with the negative emotion peaks and valleys of their inner life. It's the positive emotion they have a really hard time with. So in a lot of cases, if we can help, let them just help them help themselves, allow in a positive experience. Like, that person just said something really nice about you. Can you just let it feel good for 20 seconds? It doesn't have to be a lot longer, just a little bit, because that's what they struggle with. They often have an overwhelming number of negative stuff going on, and they have a much more ambiguous relationship with positive feeling. So that ends up being a slightly different focus of treatment and intervention than helping them deal with the negative stuff, if that makes sense. There are links to a variety of other things. I'm not going to go through all these. I think probably all of us know it's comorbid with a bunch of other typical things that come up with young people and adults. I'd say the strongest comorbidity is with disordered eating. And within disordered eating, you find about 25% of individuals with an eating disorder will have self-injury, and vice versa. But within the disordered eating categories, the one that's the most likely to co-occur with self-injury is bulimia, because they're more likely to want immediate satisfaction. There's also a moderate association with non-psychiatric risk behaviors. They can be psychiatric, obviously, but not always. It's sexual risk-taking, alcohol use, and non-prescription medical drug use, but mostly it's this top category you're going to see the most overlap with. It was added to the DSM-5 as a condition in need of additional research, and I think in the next DSM there will be an NSSI category, but at this point we don't have that. That's a mixed bag either way. Does it lead to suicide? No. It's a way of managing feelings. It is a risk factor for suicide, though, so suicidal intent really should be assessed, as I said earlier. And history of self-injury actually can make it easier to take the steps of attempting or committing suicide if this person begins to feel suicidal. That's been one of the most kind of interesting things about looking at this longitudinally is self-injury doesn't lead to it, and somebody who uses self-injury to cope with feelings isn't going to use that method to attempt suicide if that's where they go at all. In fact, they're separate. But the very act of physically and mentally damaging the body that requires breaking through personal taboos and social taboos that if someone becomes if somebody becomes suicidal, it makes they know how to do that. They know how to do that in a way that most of us wouldn't if we didn't have that experience. I tend to think of the relationship between self-injury and suicide this way. There's this common brass down here, usually some form of distress that can come from one of these three areas, but more. That's just some examples, coupled with inadequate coping. And by that, I would mostly mean they just have a limited repertoire that they prefer to use. They often know how. They know how to go do other things. They just really prefer this. And it can lead to non-suicidal self-injury, and that tends to go one of three directions over time. You can go to the left, where people do resolve this and they go on and live really great, healthy lives. There's a subset of people who go through the middle. It's just they continue to use self-injury or eating disorders or drug use or something to deal with the feelings that they have for a long, long time, well into adulthood. And then 35 to 40% of them will have suicidal thoughts or feelings at the same time or later. And that's the group we're all trying to figure out. Everybody's important, but that group, you really just don't want them to get on that branch, right? Because you want to keep them here on the planet and hopefully moving toward that left side of resolution and healthy coping. So it does appear to lower inhibition, which is what I said earlier. And the risk to moving to suicide is predicted by over 20 self-injury incidents in life, low sense of meaning in life, which is one of the primary predictors of suicide. And interestingly, and something I didn't expect to find, and we assessed relationships with everybody, peers, other adults, therapists, parents, poor relationships with parents. The upside is that when a relationship with a parent is good, or at least not damaging, it can be a huge protective factor. So these are the three risk factors for moving to suicide that we've found. Why? All right, so everybody always wants to know why. When you ask people how it helps, these are the kinds of things they're going to say. It's primarily the things in this regulate negative affect or no affect, so basically dealing with feelings. But they also talk about social communication and belonging, what we think of as self-punishment and deterrence. So I need to hurt myself because I've done something wrong, or I do a self-injure so that I don't commit suicide. Sensation seeking is kind of an interesting category I'm going to talk about in a second. And then just to distract oneself from whatever rumination or whatever thoughts they're having. So I want to just take a quicker look at three of these. So this one, the regulate negative affect, is definitely the one that comes up all of the time. If you have a young person or an adult who self-injures and they sort of regularly do this, I guarantee that they're going to talk about the way it interacts with their feelings, the way it helps them to deal with their feelings. And these are the things that show up, and the percentages are the number of people who self-injure who will report that this is why they do it. Social communication and belonging also shows up, and it's kind of interesting. This is really hoping that people will notice. Sometimes shocking or hurting someone is a goal, and then to be part of group membership. The sensation seeking is kind of interesting because you never ever see people with fewer than 6 to 11 non-suicidal self-injury incidents talking about this. This is something that seems to be engagement of the endogenous opioid system or some neurochemical process that comes online after they've injured for a while. So it doesn't start out this way, but it can certainly become a real reinforcer for self-injury, because some people definitely will say it actually helps them they get a surge of energy. There's some pretty interesting data on why it works neurologically, that when I learned this a few years ago, I had one of these, I get it moments. So I quickly want to tell you about that. In general, studies of biological and neurological basis of self-injury show that people who self-injure possess higher physiological reactivity to emotional stimulus. So, like I was saying, there's more perception, and they tend to physically feel it in their body more acutely than anybody else, or somebody who doesn't injure or have this perceptivity. They have a hard time, though, down-regulating negative emotions, regardless of the source. They just can't calm down as quickly as others. And they have less physical pain perception when they're emotionally aroused. So when they're not emotionally aroused, a cut hurts the same for them as it would for anybody else. When they are emotionally aroused, those physical pain perceptors are dampened, and they just don't feel it as much. That's one of the reasons they're at risk of going deeper, cutting deeper than they would otherwise. So this is because there's this interesting thing called pain offset that relies on some interesting studies that show a variety of things. And I don't have a lot of time, so I'm going to try to move through this quickly. But basically, there's this parts of the brain that regulate physical, social, and emotional stimuli. And we used to think that there were neural circuits that were established for just one purpose, like there was one part of the brain that governs vision and so forth. But we know that that's not true anymore. We now know that there are neural circuits we all have that are redeployed to serve additional purposes. And sometimes they're happening, those core functions are happening at the very, something got cut off there, at the very same time. So there's two parts of the brain called the anterior cingulate cortex and the anterior incellate that process visceral information. So if I pick up a cup of something warm, it's what's telling me you have something warm in your hand. It's physical, visceral information. It's what tells me there's a cool wind blowing. It's also processing emotion. So if you and I were all in a room together, it would be telling me, that very same network would be telling me how I perceive that you're thinking about me right now. So it's really strongly implicated in the affective component of pain. It sort of weds emotion and physical perception together. So there are pain perception areas that are fascinatingly, something like Tylenol that targets the ACC-AI can actually reduce emotional pain too. I am not advocating Tylenol. Please don't know I'm not advocating Tylenol, but it's fascinating. You cannot take ibuprofen, but Tylenol does help downregulate these pain perception areas because it targets physical pain centers that are overlapping neural networks. So it leads to some really odd interpretations. So I always tell my students, based on what we know now, if you go, if you are going to an interview, and then it's nice to bring some warm beverage like coffee or hot chocolate or something, because people, when they're holding something warm, are more likely to interpret someone they meet new as warm. Because their same brain networks are evaluating the physical experience and the emotional experience. Isn't that fascinating?
Yes, yes.
So it suddenly makes this relationship much more understandable. So here's like really pathetic attempt to try to visually depict this. So basically what happens with people who injure is they have an event, there's some kind of neural that activates the neural network that says, I don't like this. And their subjective neural experience of it is very big, it's very pronounced, and they're way up there and they cannot bring it down. It's really tough for them to downregulate. That becomes the treatment piece of things, is you really have to learn how to breathe and do all the things that you need, and just give it a little time to kind of start having that yellow lines come down the other side. What they've learned, though, what these individuals have learned is that, so let's say the yellow line is that same event is happening. If at the peak of that yellow line, when they're really feeling discomfort, if they physically injure themselves, or even actually imagine it, which is kind of a whole other fascinating thing, the neural network that is processing, I don't feel happy, I feel very distressed about something, will turn its attention to the physical pain. And once the peak of that physical pain happens, the big ow, we don't stay in ow land forever. It tends to drop off over time, and it basically takes the emotional pain down with it because it's the exact same neural network. Does that make sense?
Yes.
It's really quick and easy. It is way easier than trying to figure out how to do this in another way. And I was like, oh, when I got this, and all this started to become clear, we're like, oh, it's actually quite clever. If it works for you, it works fast, easy. It doesn't require a substance or anything outside of you. You can use your fingernails, actually. So some of the wild takeaways is that this uses a pain offset neural network that is normal for all of us. So when a knife, flame, or similar stimulus hits the skin, but when it's removed, the sufferer feels much better. And for people that injure, that much is actually really big. It's not a small much, it's a big much. And that leads to this very pleasant feeling of relief. And because of the AI-ACC overlap, emotional and physical pain perception are yoked together. So they're processed in the same part of the brain. When one decreases, so does the other. So for people who injure, small decreases in pain intensity equals a really powerful decrease in pain perception, and also reduce negative feelings and enhance positive feelings. I cannot tell you how much this helps people to make sense and to have compassion for it. What's kind of interesting is one of the activities that reduces ACC-AI arousal more than anything else is touch, and it gets also very, very fast. So I know, for a lot of the people we work with who injure, trauma history and touch is a complicated thing sometimes, but it turns out that even self-touch, like on the whatever part of the body that feels soothing, can help. Tapping can help. Walking in grass or having connection to earth helps. Touching animals helps. So it's almost as fast and as quick as self-injuring, actually. And it's also free. So I'm mindful of time. Okay, I'm going to just do a little bit more, and I want us to have a few minutes for Q&A. Does that sound good?
Yes, thank you. That's fabulous, Dr. Whitlock.
Yeah, I know. I was really like, there's going to be a lot of slides. I don't know if I'm going to get through them all, but I wanted you to have all of them. You'll have all of them as a PDF, and most of them, especially the referral and assessing and that kind of thing at the end, are you don't really need me to talk you through it.
Okay.
Contagion, yes, it does happen. As I mentioned earlier, it tends to be contagious in institutional settings in schools, and the people who, of course, have most emotional ups and downs or who struggle with other mental health challenges are at higher than average risk of adopting the practice via contagion. The person who's typically sort of the contagious agent is often somebody for whom self-injury is their primary mode of coping, and they're a high status peer in some way. They don't always have to be like high status everybody in the school, but if there's some set of people who think they're pretty cool, then they are definitely a potential vector. So our recommendations for handling contagion is to ask whoever you figure out might be the sources of the contagion to limit overt discussion and display of fresh wounds. If you do focus group sessions, I don't mean focus group as in research, but like if you're doing group discussion sections or treatment sessions, it really should focus on underlying feelings and other ways of handling feelings rather than self-injury or even the narratives about why self-injury injures, because the narrative reinforcement can also prompt self-injury in others. And then it's really useful to identify and engage the individuals sort of at the epicenter as partners in not spreading the behavior, if at all possible. It's not always easy to form a collaboration with somebody who's in a lot of distress and who may be injured. But if it's possible to engage them as an ally or help them understand why this is problematic and ask for their support, it's good for not only other young people in the system, but it's really good for that kid. Because so often self-injury is an active agency. It's an active voice that says, I feel disconnected. I don't feel seen. I don't feel cared about. And if the system responds saying, we need you to really stop what you're doing, especially as it's affecting others, but we do care and we want you to work with us because we recognize that you have power, it can be very healing and helpful. I know it's not always possible, but it's ideal. In terms of intervention and treatment, these are the most common treatment modalities now. Everything on the left-hand side of this column. I got to say that, I feel like I keep saying this, but we don't have a lot of studies on treatment effectiveness. And I think partly it's because there's not a lot that's profoundly effective with self-injury. It's like a lot of other addictive behaviors. People don't stop until they want to. So for a lot of therapists, it doesn't even become it's not a therapeutic goal, because if the person doesn't want to stop, they're just really not going to. It's often helpful to get a sense of them on a scale of 1 to 10. How ready are you to let this go? And if it's less than like a 7, it's something to keep an eye on and to do safety assessments around, but make sure that they know how to treat wounds. But you're really not going to talk them into it. If we look at what the components are that do seem to be effective when things work, they all focus on problem solving. So basically they focus on dealing with emotions and dealing with cognitions. So CBT, cognitive reframing kinds of techniques can be really helpful. Mindfulness shows up a lot, helping people come into the present, to breathe, to forget for a moment, to take a pause from all the stories about the past or the future that tend to churn up a lot of emotion. People will talk about they were able to stop when they learned to just live through the 15 minutes of a serious urge, because it really doesn't stick around for that long. When they move their body from one space to another, I can't tell you how many recovery stories I heard about. I was able to stop when I when I learned to get up out of my room and go walk outside, just take a walk for 5 minutes. When I had to walk from where the phone used to be, back when phones actually were like attached to a wall, into my bedroom, and it was that 20 seconds that it took me through the kitchen where someone might be made all the difference in the world. They're all usually around those kinds of things. We're basically trying to help them get through that that yellow line that's sitting up there without doing the quick and easy injury to bring everything down. They need to learn how to do that. And as I said earlier, to allow in positive emotion, because that takes the edge off the ACC-AI too. So the core components are emotion literacy and acceptance and regulation. You want to increase that, help them work with negative cognition and self-regard. Interestingly, there's usually low aversion to pain and blood for people who self-injure, not surprisingly. How you increase aversion, I'm not totally sure, but that's one of the recommendations. Help people tolerate distress and adversity. And that's usually just letting them helping them figure out how to live through that 15 minutes in the short term, and then how to just be as comfortable as possible with the discomfort of life, which is a constant, it seems like, especially if you're young and especially these days. Help them learn how to increase coping repertoires, help them to learn how or not just them, but to engage full social ecologies and contexts. And then really what people who have successfully stopped injuring say is you need to be able to practice some alternatives when you're not triggered. Don't wait till you're triggered to decide you're going to go to the gym or do some yoga or take a walk. Practice it in untriggered times as well as in low, like small trigger times, so that it becomes somewhat, you can imagine what it feels like when you're seriously triggered to actually do that. Okay, I'm going to stop here. I'm just going to populate this. You'll have the rest of the slides, because the rest of the slides really just talk a little bit about this model. And I think this is a good place to talk and do Q&A, or stop and do Q&A.
Well, thank you so much. That was very interesting. And when you got towards the end around interventions and treatment modalities, because one of the questions lingering in my mind was about mindfulness or some kind, when you see adolescents, it's not uncommon that emotional dysregulation, right? And part of me thinks it's a cultural, a lot of people are dysregulated wandering around the world in the US right now. So how do we help them get to that place with that breathing and being able to regulate their emotions? The way you put that together really made sense for me. And I thought about how could you reach out and just touch somebody on the shoulders, give a few minutes to breathe and just work, make it your goal to figure out how to emotionally regulate.
Yeah, that's such a great question, and it's always tough because I do agree. I feel like creating cauldrons of stimulus and demands and expectations and possibilities that are just really at odds with healthy development and healthy human functioning.
Mm-hmm.
We kind of make a lot of money off of it. The collective we. So it's really tough to create. It's not that it's hard. It wouldn't be hard to create environments that are really good for development. We know lots about how to do that. We're just sort of egotistically not willing to do that collectively. So
right.
It's really tough.
Yeah.
In terms of helping kids, you got to make it kind of fun. If there's a way to get groups of kids involved in learning to breathe, learning how to do 5-minute meditation, doing yoga, because even the yogic posture, some of them can be really helpful, even if it's not conscious, in the way that it stimulates different parts of the body.
Mm-hmm.
Walking, being outside in nature, being able to practice, like, okay, where can I touch myself? I know for me, for example, my forearm is a really good place, or my belly, right? Like underneath my breastbone. If I get really agitated, I can just rub it there for a few minutes and I can feel myself starting to breathe again. If you have a best friend, you can ask them to braid your hair, these aren't big, these aren't expensive, and they don't require a lot of time. It's just some degree of conscious training, and then people have to be willing to do them.
Right.
And that's where, like, parents, the biggest factor is to helping them figure out where they do and don't have control.
Mm.
And the same for all of us, there's only so much we can do. We can't crawl into another person's skin and live their life with them as much as we know in that moment exactly what should happen.
Right. I would like to ask anybody out there in Zoom land or here around the table if you have any questions for Dr. Whitlock before we close out our session.
I did want to, in case anyone wants to type in Zoomland, thinking about this as like a primary care clinician, when you first identify this, you see this, can you give some guidance about what's the best way to respond? What should I, as a primary care clinician, say to, how do you get started? I heard you can't just say stop it, and that you want to start to get their investment in changing. But in that first few moments for you, what would you recommend?
These. And this is, before I send you the PDF, I'm going to put one slide back in I took out earlier this morning that was actually kind of a conversation that you might have to say with a parent. But we would recommend what we think of as respectful curiosity questions and be straightforward. So respectful curiosity is a combination of both respect and curious. It's the kinds of questions that signal I'm interested, I'm not going to attack you or judge you, I really want to understand, and I acknowledge. So for example, if you notice wounds, you can say, you have patterns here that make me think that you have a self-injury history. Is that true? Be straight up, but it's not so much the words as the orientation of the asker. So it's amazing how attuned we all are to each other's sort of mindsets, right? We all know that. It's really often not the words, it's the tone, it's the true authentic sentiment. So if you can adopt a respectfully curious attitude and ask questions like this, I think the can you help me understand STEM is really helpful. Can you help me understand how you're feeling? Can you help me understand a little bit about your history? Can you help me understand how this helped? It seems like, so that's really validating. You may be having strong feelings. It seems like you have maybe cut yourself to feel better in the past, because if the wounds look like they're healed, is this something that you use to help yourself feel better? And can you help me understand how it works for you? You're basically opening a door. I think, in a primary care setting, it's a little trickier because you don't have an unlimited amount of time to have a therapeutic session. So you probably need to be thoughtful about what kinds of information you're going to want to get that signals I care, I notice, I acknowledge, I see, I care, and I need to understand a little bit about what's happening so you can acknowledge it in the chart and hopefully do some referrals. So it might be worth thinking about what those realistic and reasonable questions might be. But I think that the primary communication is I see, and I'm not scared, and I'm interested. And interestingly, in our studies of who people disclose to, physicians are regarded as a fairly trusted source of information and a trusted place to bring disclosures.
Oh, good.
Yeah, I know. It's kind of interesting. They're not way high up on the list of that's where people go most commonly go to peers or parents. But in terms of how did that conversation go? Did it feel helpful? They're way up there.
Okay.
I think it's because they're more likely to be a little more, there's a distance, there's not as much emotional charge.
Yes. Well, it doesn't appear, Dr. Whitlock, that we have any questions coming in from out in Zoom land. So I think we could.
I do have a question.
Oh, perfect. Great. Come in.
Hi. So my name is Tibet, and this question kind of goes along to what Jane was asking. So during the presentation, you mentioned, try to find out if we don't have that much time with the client, try to find out how many times they've done it, that kind of assess the severity of the situation.
Yeah.
And so my question is, does the severity and occurrence or, the type of injurious behavior they're using, does that affect the type of treatment that we need to use for different, I guess, types of severity of situation?
That's a good question. And so far, there's not a lot of research to guide me, but I would say we're not finding that form or function, like what people do or why they do it, is hugely predictive of how their healing trajectory or what modalities you might want to use with them. So I don't even ask, for example, about function anymore, because I know that everybody's using it for affect regulation for the most part. I know the triggers tend to be interpersonal for the most part, or something around performance. And the big questions are, you're trying to assess how common, is this your primary thing? Is this your primary go-to? So is this something you do a lot? You've done a lot? I don't know if you have the capacity to put things on intake, but it might not be a bad idea to have a couple of intake questions about self-injury history. And then if there's a yes, that there's history there, then you could have a little checklist of forms that people have used, because then you're automatically, and number of times. And if you get that, you automatically can classify people to some degree or another, and you have information to talk with them about. Does that help?
Yes, absolutely. Thank you so much.
Sure.
Any other questions, participants?
I have a question. I'm just curious about, like the study where, like it shows like the brain and stuff.
Yeah.
So like for regular, well, not regular, but just like for any of our members, we usually do like referrals to counselor, maybe DBT and stuff like that, and psychiatry. But like, would a neuro referral like to a neurologist or a neuropsychiatrist, like where would we get like that information?
I don't know that that's necessary. I mean, you can, because there's not a lot of treatment implications. I mean, one of the things that's interesting about the whole pain offset neuro piece is that it's a normal mechanism. We all have pain offset. We all have that we all process the same kinds of information. What people who have who self-injure it's just a little more exaggerated. Like the physical perception and the mental perception, the emotional perception is a little more intense, and the pain offset, that relief that comes, is more intense.
Okay.
So it's not, you're not going to see anything more. You're just going to see a normal functioning mechanism you're going to say this is an important thing for them. So the implications are still going to be the same in terms of treatment. And I forgot to mention that, like, of all the treatments, the one that people seem to converge on over and over is DBT, for other reasons I'm sure it makes sense. The mindfulness component coupled with some of the CBT stuff is helpful. But yeah, I think it's a great question, but I don't think that it's necessary to go outside of the typical therapeutic model.
Okay, thank you.
Yeah. Most people need it's amazing how much validation will do. A lot of people who injure feel pretty invisible. They feel really weird. They don't understand necessarily why they do what they do. It can be really helpful for them to understand neurologically what's happening. The more we can cultivate self-awareness and self-understanding, I think the more tools we give people.
Yes. Well, this was great and informative, and we sure at Envision we appreciate you coming on again and helping our providers put this in context for their practice. And I think we can end our session. We're at time, and I hope everybody has a really great Wednesday. Let Elena know if you're still on so we can offer CME and CEUs. And Dr. Whitlock, thank you so much for your time.
Oh, you're so welcome. And I'll send you guys the PDF you can send out. It has resources at the end.
All right. Thank you very much.
Thank you.
You too.
Bye.
Goodbye, everyone. Chime in on the chat box if you want your CMEs or your CEUs. And we'll give a few minutes before we'll close out the meeting. And